Of head and neck. Last section. So we're going to talk about the neck muscles and the triangles of the neck, and then what else is in those triangles. So we've got some compartments of the neck. So the first compartment is superficial, and it contains the platysma. Then we've got the deep investing fascia, and it's got the sternocleidomastoid and the trapezius, so you can see this outlined right here. And then right around our vertebra, we've got the prevertebral fascia, and it covers the vertebral column and the associated muscles. Right here in the front in blue, we've got the pretracheal, which is our trachea, esophagus, thyroid, and parathyroid. And then right back here, you can see in green, it would be the bucopharyngeal fascia. And then right around our vasculature, we've got our carotid sheath, and that is composed of the common carotid, internal jugular vein, and our vagus nerve. So remember, internal jugular vein is in the carotid sheath. Okay, so the retropharyngeal space is that space that is between the bucopharyngeal and the prevertebral fascia layers, and it is a potential space. So let's say infection gets in there, it can contribute to the spread of it down to the superior mediastinum. Here's this platysma muscle. It's the most superficial that you come to, and it's innervated by cranial nerve 7. So we've got our scalenes between our superior and middle scalenes. We've got, our anterior and middle scalenes. Sorry about that. We've got our brachial plexus, and then also our subclavian. If for some reason a person has a cervical rib where a rib is coming off of the cervical vertebrae rather than also normal off of the thoracic vertebrae, it may compress this. So that might be something that you may see or find in lab. You just want to see that it's going, that the brachial plexus and subclavian artery are going between anterior and middle. So we've got our suprahyoid muscles. That's the muscles that are located kind of under your chin. So, and that's going from your chin down to that hyoid bone, and that is like a floating bone in our neck. And we've got the stylohyoid, the digastric, mylohyoid, and geniohyoid. So something that's important that you need to know from this is, of course, where what these muscles are, and then also what the innervation of these are. So these are making up the floor of the mouth and elevating that hyoid. So a lot of these have hyoid in their name: stylohyoid, mylohyoid, and geniohyoid. So you know they're attaching to the hyoid. And then the other part, it's usually what it's attaching to. So like stylohyoid, stylo process to the hyoid. So the way that I remember it is that muscles going directly to the mandible get the mandibular branch V3. So mylohyoid is the most superficial muscle under platysma, and it's innervated by V3, that mandibular branch. The muscles that are going around our facial nerve, so that would be between digastric, posterior belly, and then the stylohyoid, are going to be innervated by cranial nerve 7. And then anything that's really deep is going to be C1. So geniohyoid is going to the mandible, but it's going under mylohyoid. So it's deep, so it's C1. And so we can see the muscles right here. Our infrahyoid, our strap muscles, these are going to be innervated either by ansa cervicalis or C1. And so they're called strap muscles. They kind of look like seat belts. They're going from the hyoid down. So the way I remember the innervation here is anything attaching to the sternum, I think of to the chest, so to the sternum or to the shoulder, is going to be ansa cervicalis. So we've got our omohyoid. So omo meaning shoulder to our hyoid. We've got the sternohyoid, so sternum to the hyoid. Then we've got our sternothyroid, so that's going to be sternum to our thyroid cartilage right here. Those are all ansa cervicalis, and they're helping stabilize and move the hyoid during swallowing and speech. And then something that's deep, again, thyrohyoid. It's going from that thyroid cartilage up to our hyoid, and so it gets C1. So this is just looking at it again. Here's our ansa cervicalis. It's coming from C1 through 3. Here's our hypoglossal nerve. Everything in blue right here is going to be sensory. So we've got our transverse cervical, supraclavicular getting right above our clavicle, and then greater auricular, lesser occipital, and that is getting around our ear. Okay, so we've got triangles of the neck. I know they went into a bunch of detail about this, and it's got all of these labeled right here, but a big point is that we've got in our posterior triangle, we've got the carefree and the careful triangle. So the carefree triangle, we're missing cranial nerve 11, but careful triangle, it's going to be inferior to cranial nerve 11, containing that brachial plexus and subclavian artery. So that's really important if, let's say I don't know, they're doing surgery or something, they could accidentally cut the brachial plexus or subclavian or something like that. So just make sure that you know that that is inferior to cranial nerve 11. So we've got our thyroid gland, and you'll learn more about that when you get to the endocrine part of physio next semester. And then just like you've learned in MFM, it produces thyroid hormones and calcitonin. And then right above it is going to be our thyroid cartilage. And then the prominence, or our Adam's apple, is the laryngeal prominence. Okay, our parathyroid glands are located inside our thyroid, and it's producing PTH to help regulate the calcium and phosphorus. So it's getting its blood supply from the inferior thyroid artery, and remember that's coming from the branch of the subclavian artery, that thyrocervical trunk. So it's that vitamin C and D, it's that T, thyrocervical trunk, and then coming from that is inferior thyroid. Remember that superior thyroid, getting the top of the thyroid, is coming from the external carotid. So that's something important to remember. Remember, superior thyroid from external carotid, and then inferior thyroid is coming from that thyrocervical trunk. And so here's just looking again at that from our subclavian and all the parts. There's that thyrocervical trunk, and here's our inferior thyroid. And here's the branches of the external carotid. And remember that superior thyroid is going to be in there. So a way of remembering it is some aggressive lovers find odd positions more stimulating. So starting from the bottom and going up, we've got superior thyroid, ascending pharyngeal, lingual, and remember that's traveling with the tongue, with hypoglossal, and then facial, and then occipital, and then posterior auricular, and then maxillary, and then superficial temporal. And here's just finding these in the lab. Okay, so we've got a carotid sinus and body. So the carotid sinus is a pressure receptor or a baroreceptor. It just means the same thing. And it's detecting that change in pressure, and so that dilation of the internal carotid artery. Whereas the carotid body is a chemoreceptor, and it's looking for, it's detecting a difference in levels of oxygen. And it is like a little mass deep to that carotid bifurcation. So you can see it right here in the picture as well as right here. Okay, so veins of the neck. We already said the internal jugular is going with our cranial nerve 10 as well as our common carotid in that carotid sheath. And then we have our external jugular from the posterior auricular and retromandibular veins. You're draining into that subclavian vein. You can also have anterior and connecting, but they're not all present in all of our donors. So here's just looking at that cervical plexus again, just for completeness sake. And here's looking at it on a donor. So let's talk about the nasal cavity and the paranasal sinuses. So our sensory innervation is coming from V1 and V2. Then we've got our greater and deep petrosal getting our autonomic innervation. Our arterial supply is going to be the castle plexus. And then we're going to talk about some clinical correlates. So here's our cavity. This is a big chart, looks kind of confusing. It's important to know what the openings and what they connect to. Some of the most important ones would be the superior meatus is going to connect to the posterior ethmoid sinus versus the middle meatus is getting maxillary anterior ethmoid and frontal. So make sure that you know superior goes with posterior ethmoid and middle goes with anterior ethmoid. And then the inferior meatus connects to that nasolacrimal duct and eustachian tube. And here's just looking at it again. And here's just labeling things. Here's our posterior view, and remember that vomer is in the middle. Okay, remember when we were looking at innervation of the face and V1, we said that the forehead is mostly composed of V1, the cheeks and maxilla is V2, and then the mandible is V3. So, except that V1, the nose, it's the forehead plus it goes down to the tip of our nose. And so that you can see right here in yellow, that's all V1, and everything behind it right here and getting our maxilla is going to be V2. The parasympathetic is going to be the greater petrosal, and it's getting postsynaptics from the PT ganglion. And then our deep petrosal is sympathetic, and it's getting postsynaptics from the superior cervical ganglia. So our arterial supply comes from Kesselbach's plexus. It's the most common site for epitaxis, which is just nosebleeds. And it is formed by the maxillary facial and ophthalmic artery. And remember that ophthalmic came off of the internal carotid artery. So we've got the sphenopalatine artery and greater palatine artery. And then from facial, we've got superior labial and lateral nasal, and then ophthalmic, we have anterior and posterior ethmoidal, and all of these just form this plexus right here. Okay, so we've got paranasal sinuses. Our frontal portion is going to be innervated by that supraorbital branch of the frontal nerve, V1. Ethmoidal and sphenoid are the ethmoidal branch of nasociliary, V1. And then maxillary is going to be the superior alveolar branch, V2. And you can see it color-coded in these pictures right here. And here's just looking at it on a X-ray because they could ask you it in this way. Remember, this is the orbit. Here's our frontal sinus. You can kind of see how it's a little bit darker. Right here, we've got our ethmoid sinuses. Here is our nasal cavity, of course. And then right here is going to be our maxillary sinuses. So in EPC, we feel the patient's forehead and their maxilla and say, hey, is this tender? And this is why we're doing it. Okay, so some clinical correlates are sinusitis when we've got filling of mucus in these sinuses. So we can see it right here in the maxillary sinus. And it shows up right here. Okay, and then the orbital blowout fracture. So if somebody gets punched in the eye, it can go one of two places. It can cause a herniation into the ethmoid sinus or into the maxillary sinus. And then the hypophysiectomy is where they go through the nose and get out a pituitary tumor and break that anterior wall of the sphenoid sinus to get to the sella turcica in the middle cranial fossa and get out that tumor. Okay, let's talk about the pharynx. So all of our muscles are going to be innervated by cranial nerves 9 and 10. The important one to know is that all of them are innervated motor, like the motor is going to be cranial nerve 10, and then cranial nerve 9 is going to be sensory. However, there is an exception. Stylopharyngeus is the only muscle in the entire body that gets motor innervation from cranial nerve 9. So if you see a test question that's asking you about, let's say, levator veli palatini, and it's asking you like what innervates it, and you see cranial nerve 9, you know that can't be it because only stylopharyngeus is innervated by cranial nerve 9. When you're going in lab and you see a nerve piercing stylopharyngeus, you know that either A, I know it's cranial nerve 9, or I know that that's the nerve, so I know that the muscle is stylopharyngeus. So that can help you distinguish. And then we've got tensor veli palatini. That one is going to be cranial nerve V3. I sort of think of levator like I'm on an elevator, and that goes all the way to the 10th floor. And so that one is cranial nerve 10. The gag reflex, if I feel that sensation to gag, cranial nerve 9. The motor is going to be 10, but I'm gagging because I feel that sensory innervation. And then we'll talk about the epiglottis. So here's just looking at the pharynx. We've got the nasopharynx, oropharynx, and laryngopharynx going all the way down to our cricoid cartilage. So here's our muscles again. So superior constrictor is going all the way down to that to our hyoid, and then our middle constrictor comes in, and then under that is going to be inferior. And then above that, we've got our stylopharyngeus again, innervated by cranial nerve 9. It's coming from that styloid process, and it's inserting in between the superior and middle constrictors. It's separating them. So that's one way that you can figure out where it is or which one it is. It's also like it's just coming like right straight down. And so this would be the nerve, cranial nerve 9. Salpingopharyngeus. Remember salpingo meaning tube. So this is going up to our eustachian tube right here. And then palatopharyngeus is that soft palate to pharyngeal wall. And here's just looking at this again. So this, of course, is cranial nerve 9, and that is our stylopharyngeus. Okay, so swallowing, again, gag reflex, cranial nerve 9. This Stern's law trick can help you if you can't remember what it's innervated. If it has the word tensor in its name, it's innervated by V3, like tensor tympani, tensor veli palatini. If it has palate in its name, it's innervated by cranial nerve 10, unless Rule 1 applies. So we've got palatoglossus, levator veli palatini, but remember, tensor veli palatini is V3. And then if a muscle has glossus in its name, it's innervated by cranial nerve 12. So we've got the hypoglossal unless Rule 2 applies. So like styloglossus, genioglossus, hyoglossus. Okay, so here is our epiglottis right here. And when you learn about intubation, that's really important to find. And then we can see right here is our valliculae, which is where food particles may get stuck. And that piriform recess allows passage of food from the laryngopharynx to the esophagus. So if we say, hey, water went down the wrong pipe, that's where it's getting stuck right there. Okay, so here's our soft palate muscles. We've got our levator veli palatini and tensor veli palatini. Remember, our tensor is V3, levator is cranial nerve 10, and if you can kind of see in this picture, levator veli palatini is more medial, where tensor veli palatini is more lateral, and also more anterior. So anterior and lateral, and medial and posterior for levator. The glossopharyngeal may be cut during a palatine tonsillectomy, so like our adenoids being removed. Okay, so larynx and trachea. It's all innervated by our vagus. We've got true and false folds. Above the folds, it is going to be the internal branch of superior laryngeal, and below is going to be recurrent laryngeal. That's important to know. And then our laryngeal muscles, we've got our cricothyroid innervated by the external branch of superior laryngeal, and then we've got our intrinsic muscles innervated by the recurrent laryngeal. Okay, So here's our laryngeal cartilages and ligaments. It's important to know where these are and what their name is, but the way that they could probably ask, like on the practical, I would think that it would be important to know what all of these are. So if they put a piece of putty or whatever on maybe a model, that you would be able to know what it was or what attached there. And here's just looking at them again and looking at some more of these. Okay, so moving on to vocal folds. Above the vocal folds, again, is internal branch of superior laryngeal. And then below is recurrent laryngeal. And remember, both of these come from cranial nerve 10. And so we've got our vestibular fold, which is the false fold, and then the true fold is underneath. In between it is our laryngeal ventricle. And then below that is our infraglottal space. And it's infra, so it's below. And then glottic is that glottic area is going to be between our true vocal folds. And we'll see that right here. So rima glottis is that area between. So we know that infraglottis is going to be below that. Rima glottis is the area between the vocal folds. Rima vestibuli is between the vestibular folds. And you can see that here in this picture, and right here's the epiglottis. So here's just some more functions. If we force inspiration, effort closure, phonation, just more for you to look at. Okay, know what these two muscles do. So the cricothyroid muscle, it's pulling that thyroid cartilage forward and modifying the tension on the vocal ligaments. Again, innervated by the external branch of the superior laryngeal. Just make sure that you really know what that one does, pulling that cartilage forward. Where vocalis is just making this fine adjustments and tension in the vocal folds. And so these muscles are why that we can, have or not talk monotone all the time. So I'm able to inflect my voice and sound different, and make sentences sound, like a question, or just say something and mean like with an exclamation. And so these muscles are really important for doing that. Vocalis is innervated by recurrent laryngeal. Okay, the intrinsic muscles are all innervated by recurrent laryngeal. All of these muscles, lateral, oblique, and then our thyroarytenoid muscles, and transverse arytenoid muscles, they're all adducting or bringing together our vocal folds. So they're all closing our vocal folds except for one. So if we do not have that one muscle working, we're going to have a hard time breathing and a hard time opening our vocal cords and not be able to talk or anything. So that muscle is the posterior cricoarytenoid. So make sure that you know that is the only muscle that abducts our vocal folds. Our larynx blood supply, we've got, again, our superior laryngeal artery and our inferior. Superior laryngeal is coming from superior thyroid, which came off of the external carotid. And then inferior laryngeal is coming off of inferior thyroid artery, which was off the thyrocervical trunk, off the subclavian. These clinical correlates are important for boards, but probably not where you are now. You can get laryngitis, polyps, papillomas, and carcinomas, and you'll learn more about this second year. Okay, so our last section is the oral cavity and our teeth. And so we've got, again, muscle innervation. We've got cranial nerves 10 and 12. So know that cranial nerve 10, if we have a lesion there, it's going to be contralateral uvula deviation. So if I cut out cranial nerve 10 on the right, then my uvula is going to deviate left. If I cut out cranial nerve 12 on the left, my tongue is going to atrophy on the left, and it's also going to deviate left. Ankyloglossus is tied tongue. Our blood supply is going to be maxillary, facial, and lingual. And then our lymphatic drainage is also going to be important, and we're going to talk about that. Make sure you know this slide. So our sensory innervation of our front teeth is going to be nasopalatine. So it's the farthest thing out. So I think of like my nose comes out farther than anything on my face, and it's naso, and it's our hard palate. So nasopalatine. The majority of the palate is going to be the greater palatine, and then lesser palatine is going to be the molars on the outer side, on the outer portion. And then that's going to be, infraorbital, and then this small portion back here is our lesser palatine. So greater palatine, nasopalatine, infraorbital on the external back teeth, and then our lesser palatines. Here's our alveolar processes, palatine process, pyramidal process, horizontal process, and incisive foramen. So they could ask you something like, what is the incisive foramen innervated by? Nasopalatine. Okay, so here's our hatchet. So we've got our styloglossus as the handle and hyoglossus as the cleaver. This is kind of hard to ask a question about. I could see it happening like on a model in lab, so make sure that you know these. But our palatoglossus is going to be innervated by cranial nerve 10. Styloglossus, hyoglossus, genioglossus is all our hypoglossal nerve. And then again, genioglossus is C1. So you could easily see them in lab. You've got, of course, right here, we've got our myohyoid and then geniohyoid. Both of, so we've got V3 is myohyoid, and then geniohyoid is C1, and then genioglossus is cranial nerve 12. And then hyoglossus and styloglossus again, cranial nerve 12. Okay, here's our oral cavity. Here it is again. So myohyoid, geniohyoid, and genioglossus. And genioglossus is basically our tongue. Okay. Right here we can see it. The lingual nerve is running under that submandibular duct. And we're going to see that on the next slide. And so here's just getting you oriented. Okay, so we're not seeing on that on the next slide, but it is coming up. So here's just a CT level of the tongue, and you can go through this. Okay, right here. So our submandibular duct is going over the lingual nerve, so they can just move the tongue to the side, and you'll see this orientation, and they'll ask you what either submandibular duct or lingual nerve is, and you'll have to identify. Notice that the lingual nerve is really close to that third molar, and so if the mandible is fractured, it may cause damage and loss of sensation and taste to the anterior 2/3 of the tongue. Okay, so our submandibular ganglion is hanging out right here on our cleaver, and our hypoglossus is going right here to get our tongue muscles, and then our lingual nerve is coming right here, really close to those molars. And then we also have a glossopharyngeal providing that taste sensation. So the submandibular ganglion, remember that it is where our chorda tympani is going to be synapsing with the postganglionic parasympathetics going to the submandibular sublingual glands. So here's just a look at the innervation to the tongue, just an easier way of looking at it. So our anterior 2/3 of the tongue is going to be, our sensation is going to be 5, taste is 7, and motor is cranial nerve 12. So 5 + 7 = 12. And then our posterior 1/3 is even easier. It's just 9, 9, 12. So motor, remember, is always 12. And then sensation and taste are slightly different. Here's our tongue mucosa. Remember that foramen cecum from embryo? It's that vestige of development of the thyroid gland. Ankyloglossus is just tongue-tied. Here's our frenulum and our deep lingual vein. Okay, here's our oral cavity blood supply. So our maxillary artery has those three divisions, our mandibular, pterygoid, and pterygopalatine division. So our mandibular division contains our inferior alveolar, going to our chin and so on. And then our next division is going to contain the masseteric, pterygoid, deep temporal, and then also buccal, which is our cheek. Then the pterygopalatine division, we've got our sphenopalatine, infraorbital, posterior alveolar, and descending palatine. And then our facial artery is getting our lips, and the lingual artery is going to the tongue, floor, epiglottis, and sublingual gland. So just looking at lymph drainage, our palatine tonsils are going to drain into the jugulo-digastric nodes. And so our deep cervical nodes are going to the jugular lymphatic duct to the thoracic duct. So here's just looking again at our teeth. Remember that enamel made of hydroxypitate and calcium phosphate. We only have the amount that we are born with, and we can't make any more than that. So make sure that you take advantage of that, because our dentin is pretty gray. So if you want your pearly whites, keep your enamel in check. Okay, and again, here's our 32 teeth. In juveniles, we only have 20. Okay, now we're going to talk about somatic versus autonomic. So our somatic is composed of somatic motor and somatic sensory. And then we've got visceral, which is visceral motor and visceral sensory. And our visceral motor contains the autonomics, so our sympathetics and parasympathetics. Sympathetics are fight or flight, and our parasympathetics are rest and digest. So remember, our sympathetics are thoracocolumbar, and our parasympathetics are craniosacral. So cranial is going to be 3, 7, 9, and 10. So I've had somebody, well, it's actually they asked someone else, but they wanted to know how Dr. Leo asked questions. It's really important to know where the cell body of origin is located. So our somatic motor, the cell body of origin is going to be located in that spinal cord, where with somatic sensory, the cell body of origin is going to be located in the DRG. So that's our dorsal root ganglion. So make sure that you know that where these synapses are taking place, as well as the cell body of origin. Okay, so here's just looking at a big overview of how the white and gray ramus work. And I'll let you read that on your own. More important is how we're providing sympathetics and parasympathetics to our head. So our preganglionics are coming from T1 and then synapsing at our superior cervical ganglion, which is a fusion of C1 through 4. Postganglionics are traveling from the head on branches of the internal carotid artery. Entry to T1 can cause the Horner syndrome, and things that can cause this injury are like whiplash, a lower brachial plexus injury, a Pancoast lung tumor. So remember, that's a lung tumor at the apex of our lung, and then a carotid artery issue. So remember, anything injuring T1, we're having this Horner syndrome. So what's Horner syndrome? It is a condition where we have meiosis, ptosis, vasodilation, and anhidrosis. So those are like pretty big words. What does that mean? So we're basically knocking out the sympathetics. So our sympathetics dilate our pupil, but we can't do that anymore. So that the pupil's constricted. In a way, I kind of think of it as like if we knock out the sympathetics, we're basically just having our parasympathetics have their action. So we know that parasympathetics constrict our pupil. Our sympathetics help keep our eyelid open, but we can't do that anymore. So we have ptosis, a droopy eyelid. Then our sympathetics help to vasoconstrict. Well, we're not going to be able to do that anymore, so we're vasodilating. So that's making a red face. And then anhidrosis is sweating, and so our sweat glands are actually, you'll learn that they're M3, and they are going to be, if they're knocked out, we're going to have anhidrosis, which is just a dry face. Here is looking at the parasympathetics to the head. Make sure that you know that all of these parasympathetic nerves, except cranial nerve 10, are traveling on our cranial nerve 5, on branches from that. So our cranial nerve 3 is traveling along with cranial nerve V1. Cranial nerve V2 is traveling along, cranial nerve 7 is traveling on it, and then cranial nerve 7 and 9 are traveling with cranial nerve V3. So I'm going to flip to the next slide as we can sort of see that. So here we've got our trigeminal ganglion. This is from cranial nerve 5, and we've got our 3 branches. V1 is ophthalmic, going through the superior orbital fissure. Remember, it's that standing room only. And then V2 is our maxillary nerve, and then V3 is our mandibular. So we've got our cranial nerve 3 going to synapse at the ciliary ganglion, and that is our oculomotor nerve. The and this is preganglionic. The postganglionic parasympathetic nerve from cranial nerve 3 is our short ciliary nerve. The cell body of origin of short ciliary nerve is the ciliary ganglia. So that's really important to know. And it's going to our constrictor, pupillae, and ciliary body. Remember, with Horner syndrome, we said that we're knocking out that dilation of the pupil, and so we have a constricted pupil. With parasympathetics, our short ciliary is helping to constrict our pupil. So long ciliary is sympathetic, short ciliary is going to be parasympathetic. And so if we don't have this nerve anymore, if we cut short ciliary, we're not going to be able to constrict our pupil. Our ciliary body, remember, that helps with that rounding up or convexing of our lens, which makes us be able to accommodate. So we're able to read up close or drive in the dark. Cranial nerve 7 is going to travel with cranial nerve V2, and it is the preganglionic, so before the ganglia, basically. So preganglionic nerve is going to be the greater petrosal nerve. It's synapsing at the PT ganglia. And then the postganglionic nerve is going to go to our lacrimal glands in our palate. Then we've got cranial nerve 7. It's our chorda tympani. Remember, that is going and providing that sensation, or it's providing the taste, not sensation. It's providing taste to the anterior 2/3 of the tongue, and then cranial nerve V3 is providing the sensation. It's going to be synapsing at the submandibular ganglion, and the postganglionic nerve is going to the submandibular sublingual glands. We also have cranial nerve 9 traveling with it. It's our lesser petrosal, and it's synapsing at the otic ganglion. The postganglionic cranial nerve 9 is traveling with this auriculotemporal. Auriculotemporal is part of V3. It's traveling with, so auriculotemporal and postganglionic cranial nerve 9 are traveling together to go to our parotid gland. So just to point out some similarities, we've got greater petrosal, lesser petrosal, and then we also have deep petrosal. Make sure that you know the difference between it. Greater petrosal is going synapsing at the PT ganglion. It's also cranial nerve 7. Lesser petrosal is going to be going to the otic ganglion, and it's cranial nerve 9. The deep petrosal is going to be from the internal carotid plexus, and it's going to be sympathetic. That is all I have from this. I'm going to